So we had two speakers on the programme, and then an hour ago our second speaker unfortunately became ill and dropped out. So I'm really sorry to share that news. And as I said to Sonia, I know a lot of people and I am quite good at getting people to speak, but at an hour's notice, I'm not that good. And by the time we picked up the email, it wasn't even an hour's notice. So we're going to have Stephanie speak with us, but it just means we've got a bit more time to be a bit more relaxed about presentation. And then I think there's a lot of time for questions and discussions. And I think the topic that Stephanie is talking about, implementation of social prescribing link workers, I think has lots of potential for discussion around it as well. And, you know, looking at the people that are here, a lot of you are link workers. So I think this will be a really good forum to have a chat. So let me do the formal invitation first of all, the formal introduction. So Stephanie, you are Dr. Stephanie Tierney, Departmental Lecturer and Senior Researcher at the Nuffield Department of Primary Care Health Sciences, which is the Medical Sciences Division of the University of Oxford. So the work you're talking about, I believe, is NIHR funded research, National Institute of Health Care Research. And you're going to be talking about your realist evaluation on the implementation of social prescribing link workers in primary care across 7 sites in England. So may I just hand over to you, you share your slides, and I'm looking forward to this.
Great. Thank you. I'm just making my slides big. There we go. Apologies if you've come to hear the second speaker today who's not here, but hopefully what I say will be of interest, even if you were coming for the second speaker. And as Marie said, it'd be great to have some sort of thoughts, reflections on what I'm talking about, because we have got that little bit more time. So I'm really pleased to be able to talk to you about this project, which, as Marie said, was a realist evaluation, and we were looking at 7 sites across England. And this wasn't something I carried out single-handedly, so very much part of a team, and the sort of day-to-day team, myself and Kamal Matani, and Kamal's a GP academic at Oxford. We were the leads on the project. And then we also had Amadea, Jordan, Deborah, and Stephen, who were involved in collecting data with us and helping us to analyse the data as well. And then also to recognise our co-applicants. Some are on the call today, I think. So we couldn't do this without them, and they're very much a key part of the project. And then also just a disclaimer, so we were, as Marie said, funded by the National Institute for Health and Care Research, and disclaimer that what I'm going to say are my views, not necessarily those of our funder or those of my host institution. With that out of the way, let's move on to the interesting stuff around what we actually did. So back in 2020, we published a review of the literature on the link worker role. And this review highlighted the importance of buy-in to that role as a viable addition to clinical care, and also not just buy into the role of the link worker, but buy into that person, that individual who was the link worker, seeing them as a credible, reliable, competent source of support. And then for the voluntary community sector, buy-in was around them feeling that they were adequately supported in providing social prescribing or being involved in social prescribing. And this idea of buy-in was very closely linked to the idea and the importance of connections in social prescribing. That's in terms of connections to things in the community, but also connections in terms of building trust, developing relationships between the link worker and the patient, the link worker and primary care professionals, and also the link worker and the voluntary and community sector. So that really, the review underpins the work that I'm going to talk about today. And we used the review to put together our grant application, which was successful with the NIHR. The question that we set out to address in this research was this one here. When implementing link workers in primary care, what works, for whom, why, and in what circumstances? And if you're familiar with realist research, that's sort of a typical way of phrasing your question. And the purpose of this research is to really generate evidence-based recommendations on optimising implementation of linked workers in primary care. And just to say that the project is funded until January 2024. So what I'm going to talk about today is really some sort of initial findings, and we are in the process of busily writing up and finalising the analysis. The project had 2 work packages. The first work package involved our research team going and spending time with 7 linked workers in different parts of England. And what they did was they spent 3 weeks with each of these linked workers, and they watched what the linked workers were doing. They went to meetings with linked workers. They sat in on consultations that the linked workers had with patients. They also talked to people that the linked workers worked with. So they talked to patients, but they also talked to healthcare professionals, receptionists, and to voluntary sector organisations as well. And as part of this work package, we also collected documents related to the linked worker role in these different sites that we use. So that was things like job descriptions and information that was given to patients about the linked worker role in the setting. So for this first work package, as I say, we worked with 7 linked workers and we collected data around them. So the linked workers were our cases that we collected data around. And the researchers watched those linked workers consulting with 35 patients. They also interviewed 61 patients that these linked workers worked with, and they interviewed 93 professionals. That was healthcare professionals, receptionists, and also voluntary and community sector representatives. Work package 2 involved following up the patients that we'd interviewed in work package 1. We followed them up about 9 to 12 months later and did another interview with them. And this second interview was really trying to understand, did the patients get involved in any of the community connections that the linked workers proposed? And just in general, how they felt they benefited or not from that connection with a linked worker. And for this second work package, we followed up 41 of those patients that we'd interviewed in work package 1, and we also re-interviewed 8 linked workers. You're probably not going to be surprised to hear that what we found was a great diversity in how the linked worker role was being implemented across sites. There was diversity in how many people linked workers were working with at one time, diversity in how long they worked with people, how often they saw patients, how long their meetings with patients were. There was diversity in where patients were seen. So in some cases, it was remote, by telephone, by Zoom, by Teams, or it might be at the clinic, the practice, GP practice, or it might be in people's homes. There was also diversity in the data we collected in terms of whether the linked worker was working as a lone linked worker in a practice or whether they were part of a bigger team. There's also quite a bit of variation in the backgrounds of linked workers themselves, what professional and personal background they brought to the role. And then there was also variation in the amount of time that linked workers had allocated in their working week to make connections with the voluntary and community sector. Now, we've got several concepts coming from the data. I wasn't going to talk about them all today. I didn't feel that we had time to do justice to them all. So what I'm going to touch on are 2 key concepts coming from our data. One relates to the discretion that linked workers have in their role as a linked worker. The other one is around the holding that linked workers undertake as part of their role. So starting with this idea of discretion, and we've been working on this idea of micro discretions that linked workers might undertake as part of their day-to-day practice. And this idea of micro discretions relates to the actions that linked workers take in their job that might not necessarily be officially sanctioned or approved. So if we think about that idea of discretion and what we mean by that term discretion, we can see it's relating to the ability to act according to one's judgment and the freedom to make decisions within a situation. The flip side of discretion is the idea of boundaries, and these can be seen as the constraints within which people operate. And there may be an assumption that there's a shared understanding of boundaries associated with the link worker role. So where those boundaries begin and end. But our data highlighted that those boundaries were very much context dependent, were very flexible, were very movable. And it wasn't always clear that everybody working in an area understood or had the same views of the boundaries around the link worker role. So I'm going to share with you, first of all, some quotes around this idea of discretion that came from our data. This first quote came from a link worker in Site 1, and they talked about there was this rule where they worked that you only saw patients for 6 times. But the link worker said, well, as far as I'm concerned, those rules are there to be broken, and they would see people for 2 years plus if they felt that was beneficial to the patient. And then this quote from a patient in link worker in Site 3. So this link worker talked about how there were differences in the surgeries that they were serving, and that in one practice they were seeing or being referred quite unwell patients in terms of mental health. And actually they got to the point where they were having to say at this surgery, they didn't feel that they were the right person to be working with these patients. And then Site 4, again, a link worker quote. This link worker was reflecting on when they started the role. They didn't feel they were really given any support, any guidance about how the role should be carried out. And they felt it was quite daunting as a consequence when they started. So they talked about not being given guidance on what the consultation should look like, how long they should spend with patients, also where they saw patients. They felt that they got quite a bit of freedom, but in some ways that was quite daunting at the start of their role. So thinking about in our data where link workers showed discretion, and there were a number of places where we feel that link workers were showing discretion from our data. And that included the length of connection that they had with patients, the type of referrals that they took on, what training they undertook, how they built connections with community assets, how they let primary care know about what work they were doing, and how they gathered feedback and would feedback about what they were doing, including what measures they took from the patient journey. And that this got us thinking about, well, what's the function of discretion for link workers? And we feel that it's very much related to being able to develop positive connections. So discretion is used to be able to produce a conducive environment so that patients feel safe, comfortable to open up about their needs. And also it's used to curry favour almost with primary care, to show that link workers are willing to fit in and to be flexible in the approach that they take. And these can produce buy-in to that link worker role and the person delivering that role. However, too much discretion can make link workers feel as if they're being pulled in too many directions. And then in terms of boundaries, again, thinking about what are the functions of boundaries around that link worker role, seems to be about providing link workers with a sense of security, a sense of protection. It's about managing expectations about what the role will and will not do. It's about ensuring consistency in the service and provision that patients receive, and also about having a shared understanding about what that role, the link worker role, is. And again, this was seen as, from the data, suggested that again, this could help to develop buy-in to that link worker role and the person delivering it. However, too much boundaries or too much sort of constraint around what link workers did could mean that they found it then difficult to be person-centered. So thinking then about the consequences of discretion, the data suggested that having discretion can allow link workers to feel trusted and valued members of the workforce who bring to the practice their own skills, their own knowledge, and they can use this skill, their knowledge, to best be able to support individuals that they're working with. And this can all lead to job satisfaction and then to potential retention of staff. However, too much discretion can mean that link workers feel as if they're overstepping their scope, or could put them at risk of that, can put them at risk of feeling overwhelmed, and can lead them sometimes to feeling that they've not got the structure, the security that they'd like in their role. And then this can lead to job dissatisfaction and also to potentially link workers leaving their role. So there's a dilemma there about how much discretion to allow. The second concept that I wanted to talk about was the notion of holding. And we found across the sites that we worked with that link workers were doing a lot of what we would call holding. Rather than referring, connecting people to things, they were almost becoming the intervention. And when we think about holding, what we mean here is the process whereby link workers are engaging and working with people, but it doesn't necessarily mean that they're connecting people to other services. It can entail the link worker themselves emotionally containing and supporting patients on an ongoing basis. Again, I want to share with you some quotes from the data that we collected that sort of highlight, support this idea of holding. And the first two quotes come from a couple of GPs. So the first GP talks about how having the link worker role there holding patients meant that then the patients weren't coming back to them as a GP. They were going initially through the link worker. So that meant that they, as GPs, as it says here, weren't being pestered by the patients that maybe were frequent users of the service. And then the second quote from one of the GPs talked about how some of the link workers seemed to be reticent to move people on and actually had developed quite an attachment to some of the patients. And they felt that that might mean that they're holding patients for longer than they need to. A quote from one of the patients involved that relates to holding was this one here, where the patient talks about the link worker being somebody that they could offload to and how they found it really helpful because the link worker provided them with reassurance and made them feel that they weren't on their own. And then the final two quotes, a couple of quotes from some healthcare professionals, so not GPs, but other members of the primary care team. So this one here comes from somebody who says that they were recognizing that link workers and just socially issues in society were having an impact on link workers. So they were talking about how link workers were seeing more people who had housing problems, poverty, and that there weren't enough things in society potentially for link workers to refer people onto with these difficulties. And then this one here was around how this person felt that link workers were seeing increasingly complex cases, people with complex mental health needs, and that they didn't always feel that link workers had the skills or training in being able to support these people. So for us, again, we thought about the functions of holding, and we feel that there are sort of four key purposes, functions of holding in the link worker role. So link workers might be holding people while they're waiting for other services in the community, in the voluntary sector to become available. So if there's waiting lists, for example, link workers might be holding patients while they're waiting for services to become available. They might be holding patients that aren't at the stage where they're ready to try new things. They might not have the confidence. So it's about holding patients until they're ready to be at that stage when they're ready to try new things and to access support in the community. Also, holding was seen as a way of reducing emotional burden that other health professionals might feel. So that idea of link workers holding patients so that patients then weren't going back to the people who'd referred them, often the GP. And then finally, the idea of holding as a way of bearing witness to problems that link workers might not necessarily be able to solve because they were much more structural, things like housing and economics, but things that they wanted to sort of support people with, but they couldn't fix these problems. So they would hold people and bear witness to their problems as a consequence. In terms of people more likely to need holding from a link worker, our data suggested that it was people with quite complex social and/or mental health needs. It was people lacking social support or social networks. It was also those at a tipping point who had encountered a culmination of problems in life. So they might have been bereaved, but also lost their job and also be experiencing difficult personal relationships or family dynamics. And the link workers in these cases help patients to gain a sense of perspective. And the patients talked about the link worker helping them to see the wood for the trees. And link workers giving them a sense of hope. And for some people, this was the key thing, this idea of holding was the key thing that they got from social prescribing. However, holding could come at a cost for link workers. So there could be issues for link workers in terms of capacity if they are holding a number of patients and they're also getting a number of new referrals. There could be issues to do with whether link workers feel they're achieving. If they're not referring people onwards, there were some link workers who talked about they didn't feel as if maybe that was achieving what they should be as a link worker. There was some sense of emotional labour. So working with these patients, holding patients could be quite emotionally draining, especially if link workers didn't get the supervision and support that they felt they needed in the role. And then also it could lead to link workers supporting people who could be seen as associated with high levels of risk. So that's all I wanted to say about that particular project. I did want to just highlight, though, that we've got some what we're calling knowledge exchange events, where we're bringing people together in person to talk about some of these issues. So we've already had one in Birmingham. We've got one in Exeter next week. And then the final one of these knowledge exchange events is on the 16th of November. There are a few tickets left. We are sort of limited to how many people can come due to room space. But there are a few tickets left, I think, for Exeter and Sheffield if you were interested. I wanted to finish by touching on another project that we're doing that very much has come from the project that I've just talked about. So the new project that we're working on is focusing on link worker retention and thinking about ways of supporting, addressing that. So we know from our research that we're doing at the moment that link workers can sometimes feel a lack of status in primary care because they've not always got a qualification, or they've not got a qualification as a link worker. They've often got a lot of other professional qualifications and experiences in a number of other roles, but they often feel they're lacking status in primary care. And they can sometimes feel as if they're an outsider within the primary care team. And this can also be affected by a lack of supervision, a lack of support in the role. And we know that link workers are getting increasing cases of quite complex patient issues to deal with. And this can all lead to link workers feeling burnt out and to then thinking about leaving their role. And the problem with link workers leaving their role is that they take with them often tacit knowledge. So knowledge about the local area and things that they can refer people onto, as well as their skills in supporting and encouraging people to try and think about their situation and connecting them to things in the community. And also when link workers leave, the patient will encounter a lack of continuity. So they'll have that break with that person that they've come to trust and been able to open up to. So our new study is looking at factors that shape link workers' decision to think about leaving their role. So the question that we're addressing is, how do occupational self-efficacy and job discrepancy affect social prescribing link workers' experiences of and intention to leave their role, and what can be done to support their retention? So we're interested in particular around link workers' confidence in the role, occupational self-efficacy, and also the discrepancy between what their job description says and what they actually do in the real world as a link worker. So the study approach that we're taking is what's called mixed methods. So we're collecting some numerical data followed by some more narrative data. So we're going to be inviting link workers to complete a questionnaire, and then we'll follow that up with asking link workers to take part in an interview. So the questionnaire has gone live. It's online, so you can complete it online. Takes 10 minutes to complete. We've had a couple of people pilot it, and it takes about 10 minutes to complete. There are open and closed questions on there. So some questions you can tick a box. Other ones you can give a more elaborated response. You can type in your response. And the information that we're collecting on the questionnaire includes demographic information, so information about where people work as a link worker, how long they've worked as a link worker. There's some questions about job self-efficacy, so confidence in the role. There's some questions about job discrepancy, so that difference between what your job description says as a link worker and what you do in the real world. There's also a question there about, are you thinking about leaving your role in the next 6 months? Have you thought about leaving your role in the previous 6 months? And just to say that Data collection will be, confidential. So this won't be reported back to line managers or other people. We won't be naming people when we report back on what we found. And then as part of the questionnaire, we've asked people to indicate if they'd be willing to take part in an interview. They don't have to do that, so they could just complete the questionnaire. But there is an opportunity, if people want to take part in an interview with a member of the team, where we can explore some of these issues in more detail. And we're looking to interview about 20 link workers who respond to the questionnaire. And we'll be looking for variation in the people that we interview in terms of their length of time as a link worker, where they work as a link worker in the country, their level of confidence in the role as a link worker, and the amount of discrepancy they feel there is between their job description and what they do in the real world. So there is a link to the questionnaire. I've put that on the slide here. There's also a QR code here. So if anybody is a link worker in the UK or a social prescriber, you might not be called a link worker, and you're interested, willing to take part in a questionnaire that takes about 10 minutes to complete, it would be great to get your sort of feedback, thoughts. And we're going to use this information to develop some recommendations about issues to do with retention that then we can report back to policymakers and other decision makers. So it'd be really great if people were link workers, social prescribers, if they could take 10 minutes, if you've got that, to complete the questionnaire. So as I say, there's a QR code there that you can scan to get the questionnaire, or at the bottom, I've left the questionnaire link. And as I say, we're interested in hearing the views and experiences of people, individuals involved in connecting people to the local community, resources, groups, or assets as part of social prescribing. Now, these individuals may or may not be called a link worker, a social prescriber. We know that there are a number of different terms for this connecting role, but we're really interested in hearing a range of views. So I'm going to end there. That's my email. If anybody's got any thoughts or comments after today that you wanted to get in touch with me, please do feel free to do so. I'll leave the QR code there for a minute. That's the questionnaire QR code if anybody was interested in taking part. And then just finally to say that we've got a number of projects going on with our team in Oxford and other colleagues in other universities. So if you're interested in reading about some of the other work that we're doing around social prescribing, particularly we're doing work on the cultural sector and social prescribing, that's a link to our webpage. So again, please feel free to have a look at that. And I will end there and stop sharing my screen.
Thank you very much, Stephanie. That was very, very interesting. The chat has been quite busy. So I'm just going to just dial back to the beginning of the meeting, just say for everybody that came in after we started, our second speaker sadly has dropped out just before the meeting because they're not very well. So rather than having the second speaker, in case you've tuned in to hear the second presentation, we are actually just going to stay on this subject of link workers, and I think it's like the perfect subject to continue talking about. We will send the recording of this and the slide around after the meeting. Stephanie, if you send Sonia the information, we'll add in your study, and I'm sure there'll be people here that will fill it in if they're not doing it already. So that's great. And hopefully there'll be people that will be interviewed. So I kind of just wanted to go back and say welcome to everybody from around the world who's here and who's representing Indigenous communities and all sorts of cultures. So we've got quite a range of people from different countries and different continents. So I think this also opens it up to a really good discussion. So I am just going to pull up. So there were a few questions that came up. Firstly, not really a question, but I think more a comment, was about resonance with the Scottish social prescribing community link workers. I'm just going to scan up to my chat, and I'm trying to find the person. Was it?
It was me.
Yeah.
It was me, Marie. Yeah. So
do you want to say a few words?
Yeah, I'll just say so. I'm Roisin, so I work for Voluntary Health Scotland, and I'm the project manager for the Scottish Community Link Worker Network. So that's a network for community link workers who are embedded within primary care in Scotland. So we've been up and running for a couple of years now, and we're actually doing a report at the moment looking at the range and scope of community link worker programs across Scotland. And it was just really interesting, Stephanie, sort of hearing kind of your presentation, because a lot of the sort of the things that you sort of pulled out are kind of resonating in the report that we're producing. So we spent some time talking to various community link worker program leads across Scotland, as well as surveying community link workers themselves. So we're hoping that that report will be published in the next few weeks, but I've put a link to our kind of interim kind of briefing report in the chat. And also I just flagged as well that the University of Manchester is leading on a UK-wide evaluation of social prescribing community link workers. And that's another NIHR led project, and Voluntary Health Scotland sits on the reference group for that. So there are a number of sites in Scotland that are part of that research as well, as some in the UK. So I've put a link to that as well, because that research is going on currently.
Yeah.
So thanks, Stephanie. It was just really good to hear that. Well, interesting to hear that these sort of these kind of challenges and you know that the community link workers face, it seems to be sort of nationwide. And I'll be interested to hear sort of how it goes with your second piece of research as well. And also I'll make sure that I share the link to the survey with our network too, so that you can get some of the Scottish link workers filling that in.
That's perfect. Thanks, Roisin. And glad to hear that it resonates. I'd be happy to catch up at another time if that would be of use to you. And just to let people know that for the project, we'll be producing, so we've agreed with the funder, we've got 3 papers that we'll be producing, one on the idea of holding, one on the idea of discretion, and one which will very much focus on the data we've collected from patients. So those, with the holding paper is pretty much almost ready to be submitted. The discretion paper will be submitted next month, and then the patient paper will be submitted to a journal the end of this year. And we also are going to produce a short, well, it's not a short report, it's about 15,000 words report for our funder as well. So that will be available probably in the summer or spring next year. It takes a bit of time because it has to be approved by the funder before we can sort of make it live.
Brilliant. There's various things that come up in the chat as I'm sort of scanning through. So the things in one, is there any evidence around specialist link workers for particular conditions? I think Gemma, you're with the Stroke Network. I actually I'm a co-applicant on a NIHR grant for social prescribing for people with dementia, and that is actually really starting from scratch and looking at what's happening on the ground. How are people doing this role, and then building up a study to demonstrate the impact. So that's one thing. But Stephanie, have you come across link workers for other specialist areas?
So for our project, there were it was interesting. So we re-interviewed people sort of 12 months later, some of the link workers, and they definitely expanded their teams, and some of them had taken strategic approach in terms of having drug and alcohol specialist was definitely in one area. Learning disability, I think, was another area that had sort of specialist workers in as well. So there were, in some pockets, those more people who sort of specialised in different areas, but not everywhere. So the 7 sites, there was some variation. Some had gone down and recruiting specialists support, but not all of them.
And I work with another project in Lambeth and Southwark, and they're looking at financial link workers and working proactively, finding people that are in energy debt and things like that. So I think there's
at one of the sites, there was somebody who was a link worker, had a background in sort of debt advice, that sort of thing, and welfare benefits. Now, she wasn't classed as a financial social prescribing sort of specialist, but what happened was, as a team, everybody who needed issues to do with finances went to this person. But the problem was, I think she's getting more and more referrals because these are the problems that a lot of people are encountering. So that's the only danger, I suppose, of having specialists and thinking about, are they then going to be overwhelmed by need?
And there's all sorts of other things going on in the chat, but Gemma, hand over to you for your thoughts.
Yeah, because we're running a project in South Yorkshire where we've embedded social prescribing link workers into community stroke teams. We did a gap analysis and just found that they weren't connected at all into the communities. But actually having the social prescribing link worker being part of that multidisciplinary team works really well, because they're getting skilled up, but also the community stroke team are getting skilled up. And it means that that link worker can actually focus on social prescribing and not sort out messes to do with equipment and housing and rails and all that, because there's a multidisciplinary team of speech therapists, OTs, physios around them to sort that stuff out, so they can do their job. And then the social prescribing link workers are telling us we can actually do our job now, instead of sorting out all the equipment and everything else. That's not actually our job, but they're all working together. So everyone's really satisfied because everyone's getting a benefit. And I think link workers seem to be attached to primary care networks, but not really integrated into community teams that exist. And there are we've got community teams all over the place for rehab and everything. They just don't seem to me to be well connected into those teams. And it's a bit of a missed opportunity, because when you can get that, everyone wins. So it's just to put that out.
Yeah. Stephanie, any
No, it makes sense in a way. I suppose one of the things that we picked up, though, that even within primary care teams, link workers aren't always feeling integrated within them. One of the things we're working on is the idea of a continuum between link workers being bolted on, just brought in, but not thought about how they're integrated, through to hopefully embedding people, link workers, into a primary care team. But there's definitely a continuum, I think. So I think even in primary care, they're not always feeling as if they're part of the team.
Want to move on to a different subject. I'm not sure you mentioned it, but I may have missed it because I've been keeping an eye on the chat. What did you ask about the type of clinical supervision or supervision and support that the link workers were getting? That was a question from somebody. I'll find their name. It might have been Julian. I'm not sure, but
yes, we did.
Tell us about that.
So it was varied. In some cases, especially if there was somebody who'd been a link worker themselves who was then a manager, there seemed to be, and it's small numbers, we've only worked with 7 sort of link workers, but when there was a social prescribing manager in place, there seemed to be more likely then to think about supervision and seeing the priority of that. Whereas there was another case where there was a link worker working in a practice on her own, no support, and she definitely didn't feel that she had the support, supervision she needed, and unfortunately left the post for various reasons. But yeah, so I think I would say there was variation in the supervision that people got, but as we know, for the role, there was a sense that they needed it. It was not a add-on, it was an essential, but it wasn't happening in all places, or wasn't happening on a consistent basis either. It was a bit ad hoc when you need it, rather than having scheduled meetings as well.
And it's a shame as to why that is so undervalued, because no other professionals can get away with not having their clinical supervision. You know, it's part of their, I suppose it comes to whether you have a professional association that's setting criteria to be part of an accredited group of people, and that those have to be fulfilled. So that doesn't happen with link workers. So I think some of this, despite our noises that we've made for a very long time, so that was I think Helen at Nutri that came up with the question about clinical supervision. But actually, Julian, I don't know where you are. I don't know if you want to come and ask your question that you put in the chat. Are you still here?
Hi, I suppose thinking about the dynamic between the two areas, really, the holding function and the kind of discretion. And I guess I'm just wondering how much they're really interlinked. They kind of might seem to me quite interlinked, because if you're dealing with holding people, they're inevitably going to be potentially more tricky, and so yeah, so I guess there's discretion about how much you get involved with them. So the boundaries issue might come in there as well. So were there any kind of patterns in that that you saw? Was there a particular dynamic there that you picked up on?
So they're definitely interconnected. And as part of this work, we're doing something called a realist evaluation, and you develop a program theory as part of that about how you think something works. So it's an explanation, and we can very much see that we're still in the process of sort of put it all together. But in the program theory that we've got at the moment, we're trying to sort of do it as a visual, and the discretion and the holding definitely are interlinked. So there's definitely overlap. It was a bit of a, not an issue, but when we were writing the papers, a couple of points we said, oh yeah, they're definitely, so we have in the paper about discretion, we're mentioning holding, but not a lot. And then in the holding paper, we will mention discretion. It does come into, yeah, I think they are definitely interlinked.
So many things in social prescribing and so many attributes are interlinked. You know, and you talked about buy-in right at the beginning, and the very first report I wrote on the key ingredients was all about getting patient buy-in. So it's very interesting to see that come back, and the relationships we talked about, critical systems thinking, and the relationships between people were critical for buy-in as well. Elizabeth Woodcock, you had a question related to holding, I think. Are you there? Hi.
Hi, thanks, Marie. Hi, Stephanie. Nice to meet you. Put a face to an email. It's such a good network, Marie. Thank you. Yeah, I was just provoked by Julian's question. Really made me think about. So within that dynamic, did link workers have any strategies of how to manage burdensome holding? So obviously, holding's not always burdensome, but where it becomes where it's there perhaps because of a lack of services or a lack of community assets, do they co-produce those assets with the socially prescribed person? Do they have any other strategies? Is that something that you're finding is coming out?
I think in terms of strategies, again, it varied. Partly if they feel as if what they're doing is valued by either the patient or by their colleagues in terms of holding, it can help to reduce that burnout because they're feeling as if it's a legitimate, accepted part of the role. Obviously, supervision, I think, came up as a sort of key thing to help with holding, to reduce that amount of burden that people were experiencing as a consequence of that. I mean, in terms of, I think also being realistic about what they were able to do. I think not having, as a link worker themselves, accepting that there's some things that they can't do because there's not the resources, and not feeling like a failure because of that, because you can't magic housing solutions out the air or you know, new groups for people, you know, if you haven't got the capacity and time to do that. So I think part of it as well was as being realistic about what you could do as a link worker, and not beating yourself up that you couldn't solve every single problem. I think some link workers came to that recognition that it helped them then to accept that, you know, maybe holding people was as valuable for that individual as being able to, you know, put them into contact with somebody who could resolve their problems. But then is it social prescribing then, or is it a different thing that they're doing?
It opens, I think. Stephanie, what was the time frame that you were doing the research? Because obviously the COVID pandemic really changed the amount of holding that link workers were doing, didn't it? I mean, I did some work and we sort of showed literally how their role had changed. And I think there's been a lag coming out of that. And there's, I think it's forever changed the role of a link worker in a sense around holding. So I wondered how the, you know, COVID fitted in with this.
Yes, so we started data collection in November 2021.
Oh, bang in the middle.
Yes, so it's a bit touch and go, but we managed to get through with it. So I think it's quite good because we've seen that trajectory of having COVID, and then we finished our final follow-up interviews last summer. Or was it this summer? I forget. Somebody might remind. No, yeah, it was. When did we do it? Sorry, I'm just going to check my slides so I don't give you incorrect information. So our last interviews were carried out in
this summer, said Stephen.
23, yeah, August 23. Yeah, you lose track of time with COVID.
Totally, yeah.
but that was quite interesting. I think you're right that maybe they have been holding a bit more in COVID times, but then almost it's become, because a lot of the link workers started during that time, just before maybe COVID hit, it's almost become part of their role that they maybe see their peers do, or they feel that it's something that brings them satisfaction to the job as well. I mean, that was definitely something that was coming out, that actually some link workers talked about how they enjoyed, I wouldn't say holding people, but that it gave them, you know, sort of a sense of satisfaction because they were able to do something for that person. So I think that idea of holding, I think that's an interesting concept. Maybe we need to go back and look at, but definitely I would say that it's been a constant thing. It's not like COVID restrictions have stopped, so we're not holding people any longer. I think the holding in some ways has continued, because then you've got people coming into a cost of living crisis and all the anxiety around COVID and change working conditions. I think there's a lot of things that, you know, have still mean that people are being held, and then the reduction in voluntary sector provision. Yeah, I think it's an interesting idea that perhaps holding just looks slightly differently during COVID to afterwards. But yeah, maybe we need to go back and have a look at that data.
I've done, you know, various evaluations, and one of the questions on our MyCall questionnaire at follow-up is what's been about the support you've received or the service. And I can tell you 9 times out of 10 people will talk about an aspect of holding, of having someone listen to me, having the time to explain, having someone, you know, feel like they want to listen, that I'm worthy of being listened to, that there's somebody I know I can go and talk to, that I'm not forgotten. So I think all of that is probably more powerful to a vulnerable person than we ever give credit. You know, it's almost like it's a problem holding's really important. It's just how it fits into a very fixed system sometimes, I think. And you know, how go on.
No, I was going to say, what was also quite interesting, having done the follow-up, which is difficult to do, but I think was valuable, was some of the patients we talked about how when they first saw the link worker, they didn't make changes, they didn't feel they wanted to try this or that. But actually it just opened their mind up to, actually I could try different things, and they didn't try the things the link worker proposed, but maybe 6 months later they suddenly thought, actually I might give this thing a go. And they said it was very much related to those conversations with the link worker that then sparked their ability, their interest in maybe trying something, and then that forged them forwards and it transformed their life. But it wasn't directly the link worker suggestion, but it was from seeing the link worker proposing things and opening up options and making people think of things that are a possibility for them to try, that then 6 months down the line they did go and try things.
Absolutely. I think we don't have a lot of nuanced data around how long it takes for different parts of the journey to happen. You know, someone can see a link worker and it can be quite a fast change, or like you say, there's a slower time frame to it, but still very important outcomes. There were Isabella, I see your hands there. I'm just going to come back to something that Sean put in there. So there were 2 points which would perhaps take us in slightly different directions, but David from the Conservation Volunteers, or TCV, asked about data capture, and you know, that's a gap. And David, I agree with you. I think what you make is a very valid point, but I'm not going to go into discussing it right now. But we can send you the recording of the evaluation toolkit that we spoke about last time, if that would be helpful. But Sean Slade, you put a question here about how the link worker role fit with other roles, which we kind of touched on with this specialist role, but do you want to just put your question across?
Yeah, so one of the things that we're trying to sort of explicate a little bit in Australia is what's already happening in the community versus what social prescribing is providing on top, in terms of we have care coordinators and different types of roles. And we've seen a lot of navigator type roles developing in different scopes of practice. And then, of course, we have social workers. So I think when we started our calls about 4 years ago, people would say, well, I'm an OT and I already do this as part of my usual practice. And I'm sure it's, you know, information that you've heard many times over the years, Marie. But I was just trying to get an understanding of, you know, how all the roles fit together, the continuum, and just Stephanie, I remember contacting you a few years ago, actually, when we started our work, and thank you very much. I think it was your article that you wrote about care navigators that I'd contacted you on. But it was just really understanding this continuum of roles and how the different roles work together, and who's the facing role to the person, so that the person doesn't get confused by all these different people acting to support.
In terms of the person getting confused, in the interviews we did, patients often didn't remember seeing a social prescriber. They remembered seeing June or Joy, and they really liked talking to this person, but they still didn't have a good understanding of a link worker, a social prescriber. They just liked having somebody nice to talk to. In terms of the teams, again, it varied. So there was one site where the link worker had no team support. She was just a link worker that served 2 practices. In other practices, there was one practice where there was very much a lot of work done by the social prescribing lead, the manager, to integrate that link worker with health and wellbeing coaches and care coordinators. They felt very much part of a team, and they would support one another. So they'd usually, the patient would see a link worker, they would be referred there, but there were occasions that she talked to me about where sometimes somebody they felt might be better working with another link worker, so they would almost like transfer them over to that other person if they felt it was in the person's best interest. But I don't think that happens everywhere. And maybe that's another project, how decisions are made. If you've got a number of link workers that you could refer people onto, how are decisions made about how we decide which of the link worker team? Is it first come first serve basis, or are there particular decision-making points that mean that certain people get to see this link worker but not that link worker? So I think
that might be depend on the specialist background of the link worker and what they bring to their role as well. And we saw that actually when I was doing an evaluation of children and young people social prescribing. So if the link worker was working with a young person, actually what they found was often the carer or parent needed support, but they would make sure that that carer parent went to a different link worker within the team, so that there was that distinguishing. We have got some really good stuff, so I'm just drawing people's attention to the last few messages in the chat around holding, and I totally agree with everyone that I totally agree that holding is very important, and that's the reason why I set up Social Prescribing Network and all of this, and push to hear people. But I just want to finish up because we have managed to fill an hour effortlessly. Isabella, you've got your hand up, so do you want to ask your
Thanks so much. Sorry, I'm having some technical issues, so cameras and chats and things are not working, so apologies. I just wanted to quickly pick up on that point that you were saying about that delayed action by patients, and also connecting that with the satisfaction that link workers have, or that feeling of achievement. I was just wondering how much of that did patients feed back to the link workers? You know, not many link workers work with people for that long, and as you said, there is variation, but I was just wondering how much of that got back to the link workers, and maybe it's something to think about in terms of that like 6 or 12 month follow-up for link workers to be doing in order to understand and recognize that, to facilitate some of that retention and sense of achievement in their roles if people are reporting that it's delayed action that's happening.
Yeah, I mean, with that case, I don't think that person that I talked about went back to the link worker and let them know. And link workers that we talked to, they said that they only find out from patients if they get back in touch with them. So perhaps in one of the sites, they did follow up people 3 months later, but I think that was sort of the cutoff point, although they were clear that there was an open door. If the patient needed to be re-referred, they could go back. But I think you don't hear about the positives. You probably hear about people coming back to you because their life's difficult again, or they've got another issue that they're struggling with. Whereas you don't hear about those patients whose life has been transformed, as you say, but you don't hear that at the you end after 6-8 sessions. You think the person's doing okay, but then it's only 6 months later that they suddenly do something that's related to what you've helped them with, but it's really transformed your life, but you don't get to hear about that.
Thanks, that's really helpful.
And I think trying to work those ways of engineering the feedback in, and so that people that are referring to a link worker and link workers get to see the sort of the impact and success. And also, you know, if you're auditing a service, to understand if it could be, you know, from a quality improvement perspective, made better, it is really important, isn't it? But quite difficult to do, because our systems seem quite linear rather than comes back to the point that was it David was making from TCV about how we record this and monitor this and all of that. So Stephanie, I want to say a massive thank you. So you thought you were doing half the session and actually you've done the whole lot, and very appreciative of your flexibility. So just to say, it's everything is being recorded. We will send the slides and we will send this recording, and we'll pull out any links that are in the chat, and that comes through on an email. If Sonia's there, if you've got the link to the next session in November, that would be great to put into the chat, but we'll also put that on the email that comes round. So yeah, it's been a really, really good discussion actually around the amazing role of link workers. So I'm going to finish there. Oh yes, in the chat we've got the next link for the last seminar that we're doing in this series, which will be next month, and I've completely forgotten who's presenting, so huge apologies there, but go and just do the link. Oh, it's not live yet, it'll go out via the mailing list. Brilliant. Anthea from NASP, you're head of evidence at NASP, aren't you? Is there anything you wanted to say or add? Or
so just to add a huge thank you, Stephanie, that was really fascinating. So much to think about, so thank you very much.
Yeah,
brilliant.
thank you everyone for contributing, and yeah, please do get in touch or keep your eyes out for publications. And
fill in your survey. So we will send the link round again. So the more people that fill the survey in, the more the voices get heard, the more translate into policy changes and improving the job role and all of that. So brilliant. So right, so look at that, we're just coming up to 1 o'clock, and thank you for everyone that got up in the middle of the night, early morning, or wherever you are in the world. It has been lovely to have you share your time with us. Thank you very much.
Thanks everyone.
So time for lunch or breakfast or sleep or whatever's appropriate.